Welcome to EADV Live. Today's topic, new developments in pathogenesis and therapy of psoriasis. I'm Christopher Horskamp, and on behalf of the EADV, we welcome you to today's interactive webcast. If you have questions or comments about the subject matter, send them in at any time during the presentation, and our presenter will do his best to address them at the end. Today, we are joined by our speaker, Professor Luis Puig. He's the director of the Department of Dermatology at the Hospital de la Santa Creu y Sant Pau and professor of dermatology at the Universitat Autònoma de Barcelona Medical School in Barcelona, Spain. With his vast clinical research and treatment of psoriasis with biological agents, he is considered to be a key opinion leader, both nationally and internationally. We are happy to have him with us and happy to hand over the webcast to him. Professor Puig, welcome.
Thank you very much. I'm more than happy to contribute to this webcast. On behalf of the European Academy of Dermatology and Venereology, which has a task force on psoriasis, of which I am the co-chair together with Professor Joe Lambert. And I would like also to declare a conflict of interest with the International Psoriasis Council, of which I'm a board member, and also with several companies which are developing and have developed biologics for psoriasis, and in those clinical trials I've been involved, and also I collaborate with them in terms of advisorship. The topic today is the new developments in pathogenesis and therapy of psoriasis, and I would like to give you an overview of the recent advances or changes that have been made and that somehow might impact our future therapeutic approach to some variants of psoriasis, especially those forms characterized by pustular morphology. So this is plaque psoriasis, the standard clinical and histopathological appearance. We are all aware about the imbrication of both innate and adaptive immune response in this inflammatory skin disease, in which there is an activation of the keratinocyte together with a hyperproliferation and alteration on its differentiation. And this is associated with a heavy infiltration by mononuclear cells, but also with some polymorphonuclears early on, with vascular changes, and also eventually with dermal edema and vascular endothelial proliferation. And this phenomenon is also associated with local inflammation, but also systemic inflammation. And some new advances have been produced as regards the way in which we can explain this general or systemic inflammation, which might provide some rationale for the associated cardiovascular comorbidities, and also specifically for psoriatic arthritis, which I would say is the main comorbidity, if not a component of psoriatic disease per se. So this is the inflammatory infiltrate at the close-up view, and you can see the very close interaction between keratinocytes and lymphomononuclear cells, also with some polymorphonuclears. And I would like to stress the fact that keratinocyte has been recognized as a very active immune agent, which is amenable to provide a feed-forward loop of inflammation, and also to activate itself through a self-loop, which we will be discussing in the course of this presentation. The first thing that has the part of knowledge that has appeared recently is that the reaction to injury in the skin is very close to the early events that occur in the pathogenesis of psoriasis plaques. It seems that the innate response to a microbiota, which gets in contact with the immune system following a skin injury, determines an interferon-dependent response with an increase in antimicrobial peptides, which are well-known features of psoriasis, and which provide also differential as regards psoriasis from atopic dermatitis, despite the fact that in the late stages of atopic dermatitis, there might be an IL-17 activation of keratinocyte proliferation, and lichenification can provide a very close appearance. So the first thing we must remember is that the reaction to skin injury is determined by microbiota, and the innate activation of plasmacytoid dendritic cells through their toll-like receptors provides the basis for the production of interferon alpha. And this is well known to be one of the most of the earliest events in the development of psoriasis plaques. Very early on, we get this activation of plasmacytoid dendritic cells. This can be directly through the PAMs or other innate activators, but also some autoantigens, and especially cathelicidin, and also DNA that comes from the probably the keratinocytes themselves, and also defensins might also activate these plasmacytoid dendritic cells. It remains to be seen, but it's very likely that these antigens might also induce a local activation of naive lymphocytes towards T17 and T1 cells, which are the main mediators of the adaptive response in psoriasis. Early on, the plasmacytoid dendritic cells activate dendritic cells, which become professional antigen-presenting cells, both after their migration to the local lymph nodes, but also on the skin itself. So there might be a local activation, and as a result of the production of interleukin-23 by these dendritic cells, and perhaps by some other cells, perhaps keratinocytes are also recognized to produce IL-23, and this mediates the activation of naive T cells and their priming and proliferation of predominantly T17 cells. It is quite interesting to see that in some acute lesions of psoriasis, in unstable psoriasis that is changing and it's very inflammatory, in which erythema predominates, and also in erythrodermic disease, and in some cases of goutate psoriasis, interferon alpha has been recognized to be one of the main drivers of this inflammation. Whereas in the stable plaque of psoriasis, IL-17 takes helm and becomes the predominant cytokine. Let's remember that T17 can be produced by Th17 cells following the activation of interleukin-23. It can be also released by T regulatory cells following exposure, prolonged exposure to interleukin-23, and it can be also produced by natural killer cells, but cells of the innate lymphoid cells, type 3 innate lymphoid cells. And also it can be released by polymorphonuclears and mast cells. So IL-17, both A and F, are very important. And together with interleukin-22, they are the main drivers of the keratinocyte hyperproliferation and immune activation. And as a consequence of this activation of the keratinocytes, there's a release of chemokines, which attract more lymphocytes, more dendritic cells, and also some polymorphonuclears to the lesions. We must remember that the polymorphonuclears are highly accrued to a great extent in pustular variants of psoriasis. And it is well known that some cytokines of the closely related to the innate activation, such as interleukin-36 or interleukin-1 beta, and some others, are the main contributors to these pustular variants of psoriasis. So we have kind of three main drivers of inflammation and activation according to the different phenotypes or endotypes of these lesions. And also, I would like to remind you that even at this level, IL-19 is another cytokine which can be produced by keratinocytes, the same with IL-20, I-24. And these cytokines contribute to the proliferation in a self-activation loop of keratinocytes. Let's remember what we have already just commented. Interleukin-23 is the main regulatory cytokine. It drives the differentiation and proliferation of T17 cells. Also in humans, the T22 population seems to be different from T17 cells. This is as opposed as mice. And then there's also an activation of T1 cells following the exposure to interleukin-12. And there's an activation of the keratinocytes driven not just by interleukin-17 A and F, but also by other cytokines which are also produced by these cells. Interleukin-26, interleukin-29 also contribute to the proliferation. And tumor necrosis factor, which can also be produced by T17 cells, has a synergistic role. It increases the receptor, the levels of IL-17 receptors, and also it increases the effect of IL-17 on its target cells. And eventually, these keratinocytes, activated keratinocytes, take the leading role. They are able to produce several chemotactins, CXCL1 to 8 are chemoattractants for polymorphonuclears. CCL20 is a chemoattractant for T17 cells. All these cells, together with myeloid dendritic cells, express CCR6, which is a marker of these cells, which eventually are attracted to the skin. And this activation of T cells by the keratinocytes leads to a self-amplifying loop. In keratinocytes themselves, interleukin-36 and interleukin-17C, and also to some extent interleukin-25, which are produced by keratinocytes themselves and becomes activated by some enzymes such as catepsin or proteases derived from polymorphonuclears, give rise to an enhanced activation of this proliferation, of this immune activation, and the release of antimicrobial peptides, which characterize the lesions of psoriasis. That's opposed to what happens in atopic dermatitis, for instance, even though some lesions might look like the same. So this is just this reminder. I want you to remember the very important role of IL-17 as the main effector cytokine, but we always need to remember the role of interleukin-22, of interleukin-26, and interleukin-29. These might be potential targets for therapeutic approaches, but we must remember that interleukin-22 in itself is not very active when we block them with some biologics that have been available but have not reached the market. This is just a reminder of this role of the keratinocyte as a driver of inflammation, attracting polymorphonuclears, attracting lymphocytes, attracting even dendritic cells. And they have a very important role in both in the immune adaptive response as in the innate adaptive response. This is just a reminder that interleukin-36 produced by the keratinocytes activates plasmacytoid dendritic cells, that interleukin-36, interleukin-17C, and other interleukins of the IL-10 family become self-activators of keratinocytes, especially as regards their proliferation. And the role of the chemokines produced by keratinocytes is highly important in providing the accrual for polymorphonuclears, mast cells, and further T17 and T22 cells that release interleukin-17A. On the other hand, if we look into the adaptive responses, the keratinocyte might act as a non-professional antigen-presenting cells, and this might provide an explanation for the role of HLA-CW6 as the main genetic factor of psoriasis, even though we must remember that some other autoantigens, such as phospholipids or cholesterol metabolites, can also activate by another pathway T cells and even natural killer T cells. So the consequence of this activation of T cells is the release of interferon, interleukin-17, and TNF alpha, which have those synergistic roles we have just commented before. What about innate immunity? See, here it is important to focus on the role of interleukin-36, but we must remember that the keratinocytes themselves are able to produce interleukin-1 beta, interleukin-6, tumor necrosis factor alpha, and also interleukin-23. So they are able to activate the dendritic cells themselves. So this is what we are summarizing in this cartoon. But now we are including also the role of the TNF alpha and IL-17 in increasing the release of chemokines that bring polymorphonuclears. And these polymorphonuclears release proteases, elastases, which activate, they cleave pro-interleukin-36 produced by the keratinocytes, and the consequent, the interleukin-36, which is released then, the different isoforms of interleukin-36, are able to increase their potency by 500-fold and acting on the different target cells of interleukin-36. The role of this cytokine, which is relatively new, has been recently appreciated, was initially identified in a imiquimod murine model. in which the presence, the blockade, the absence of expression of the antagonist of interleukin 36 receptor induce a psoriasiform phenotype, which is very close to what happens in another experiment of nature, which is the deficit of the IL-36 receptor antagonist, which was identified initially in some families in North Africa. Mostly this was the work published by Dr. Marrakchi and the group of Dr. Bachelet in Paris. And this is a monogenic variant of pustular psoriasis in which several different phenotypes can appear: generalized pustular psoriasis, oral mucosal psoriasis, allopo disease, and this follows an autosomal recessive pattern of inheritance, and this is due to the fact that the absence of the antagonist of interleukin 36 allows an uninhibited activation of the receptor and the consequent inflammatory response. It is now known that 1/3 of those patients with generalized pustular psoriasis, which is the main the phenotypical manifestation of this disease, of DITRA, the deficit of interleukin 36 receptor antagonist, they have only 1/3 of those patients have mutations. Those patients who have mutations of the antagonist of the receptor of interleukin 36 have earlier onset of disease, are less likely to have psoriasis vulgaris in association with the generalized pustular psoriasis, and are more likely to have systemic inflammation. And depending on the genetic charge, the appearance is more early or more delayed. And in any case, the presence of these mutations increase the risk of systemic inflammation. Talking about generalized pustular psoriasis, which is a disease in which we can expect great progress to be made from a therapeutic perspective, we must remember that there are three main clinical phenotypes. One is the early infancy appearance, which is more frequent, of course, in those familial and genetic cases. There's another one characterized by generalized pustular psoriasis with relapsing flares, usually one or more per year. Usually they appear in adult patients, sometimes with associated psoriasis vulgaris, and in some cases this disease can appear in pregnancy. Depending on the presence or not of psoriasis vulgaris, and especially systemic inflammation or not, we can classify this disease. In some families and even in some patients, this generalized pustular psoriasis can coexist with either palmoplantar pustulosis or another variant, which is acrodermatitis continua of allopo. You all know of this acral destructive pustular disease, which destroys the nail plates. And also we must remember that in some patients, palmoplantar pustulosis can be not associated with psoriasis, psoriasis vulgaris. It is more frequent in in far east, in Asian countries, and it might have a different genetic background and a different phenotypic presentation. Usually affects women, usually smokers, and in some patients there is no association with plaque psoriasis. Talking about the histopathology of pustular psoriasis, we must remember those intraepidermal pustules without, in most cases, spongiosis, even though in those Asian variants, they might be connected to the crine ostia or ducts. And we must remember the great advances that have been made in our understanding of the genetic basis of these pustular diseases. But let's remember that the genes which have already been recognized only account for 1/3 of cases. And we now know that there are at least three main genes. One is the antagonist, the gene that codes the antagonist of the interleukin 36 receptor. The other one is CAR14, and the other one is AP1S3. And the results of these mutations, usually leading to loss of function of the antagonists or gain of function of, in the case of CAR14, of an activator of a nuclear factor kappa B, activation of the keratinocyte and other immune cells, they can be associated with different phenotypes of pustular disease. So, for instance, the DITRA can be associated in the same family or in the same individual with some variability with generalized pustular psoriasis, palmoplantar, allopo disease, or even acute generalized exanthematous pustulosis without psoriasis in some patients. CAR14 can be associated with both pustular palmoplantar pustulosis or generalized pustular psoriasis, and EP1S3 again can be associated with different phenotypes. It is very important to remember this activation of interleukin-36, which is released as a pro-cytokine, a pro-peptide. It becomes activated by different enzymes. Catepsin is released by keratinocytes and fibroblasts. Catepsin G is released by polymorphonuclears. There are also elastases. There are also proteases. And they cleave the different isoforms of interleukin-36. And it is also important to remember that out of the genes that are known to determine pustular psoriasis phenotypes, some of them have an activating role in terms of the immune or the pathway of immune activation determined by the signaling of interleukin-36. Some others, for instance, the case of SERPIN-A3, code for antagonists of these enzymes which activate interleukin-36. So in all these cases, whenever we have pustular psoriasis, we have an increased expression and signaling of interleukin-36. So this is just a reminder. You can see here the dendritic cells and the T cells contributing with their cytokines and activate the release of interleukin-36, which it's secreted as a an inactive proform, and it is activated, and the interleukin-36 is then becomes much more potent, and it activates a signaling that increases even more the expression of the interleukin-36 messenger RNA. And eventually, this leads to the activation of the keratinocytes with more accrual of neutrophils. This is what we must remember in this cartoon, which combines the phenotypical, the histopathological, and the pathogenic aspects of pustular disease. The keratinocyte, following this release of interleukin-36, is able also to activate the dendritic cells. And this is important because the keratinocyte has been to some extent not taken into account. It can release interleukin-36 and activate dendritic cells, plasmacytoid dendritic cells, and mononuclear cells, monocytes. And the result of this activation mediated by interleukin-36 is the release of interleukin-6, interferon alpha, which are well known to be the drivers of systemic inflammation. On the other hand, this loop of activation activates furthermore the keratinocytes. This is one of the most important concepts that have appeared, is that this axis driven by interleukin-36 and interferon drives systemic inflammation. So plasmacytoid dendritic cells become activated by interleukin-36, released by dendritic cells and keratinocytes themselves, and they release interferon alpha, which leads to the systemic and acute flares in the case of generalized pustular psoriasis, or the chronic systemic inflammation in the case of psoriasis. It remains to be seen which is the relative role of interleukin-36, tumor necrosis factor, interleukin-17, adipokines, and some other pro-inflammatory mediators in these inflammation-driven comorbidities that we all know that are associated with psoriasis. But it is quite clear that not in most cases of psoriasis, even extensive psoriasis with systemic inflammation, the high levels of interleukin-6 mediated proteins, such as, for instance, C-reactive protein, are not found. So there must be something different, and in that respect, perhaps interleukin-36 or interferon alpha might be the main culprits or the main drivers of inflammation. It is interesting to see that quite recently it has been shown that the peripheral blood cells, not just mononuclear cells, also polymorphonuclears in psoriasis are activated from the perspective of the inflammasome. So high levels of interleukin-1 beta and high levels of interleukin-18 and some other cytokines of the interleukin-1 family, which drive innate immune activation, are activated, are increased intrinsically in patients with psoriasis. So systemic inflammation in psoriasis admittedly is treated and controlled and bring down by deep treatment, and I'm thinking about the most active biologics that improve cutaneous and systemic inflammation. We must remember that the degree of improvement of systemic inflammation, at least based on the measurements in coronary or big bloods or in aorta, is not so different from what we can achieve with, for instance, in statins, but it is quite clear that systemic inflammation is associated with cutaneous inflammation. But we don't know which are the most effective treatments, and we don't know which are the circulating culprits of systemic inflammation. They might be activated T cells, monocytes, polymorphonuclears, platelets. We're always thinking about the cytokines which we are known or able to block with our available biologics, but there might be new potential pathways. We've just been talking about this interferon-1 mediated activation, the interferon released by interleukin-36 receptor activated plasmacytoid dendritic cells. And there's another option through this activation of the inflammasome mediated by tumor necrosis factor in peripheral blood mononuclear cells, which releases interleukin-1 beta and interleukin-18. So this is just a summary of the two important papers that have been published focusing on these mediators of systemic inflammation. Then we can speak about interleukin-36 inflammatory triad, in which there are polymorphonuclears that activate the propeptide. There are interleukin-36 acting on epithelial cells, and also on interleukin-36 released by epithelial cells, which acts on dendritic cells. And the target cell types of these interleukin-36 are very numerous, and this determines their pleomorphic effect. This is just a remembrance that the interleukin-36 is just one of this family of cytokines. One of the initial one that was recognized early is interleukin-1 alpha and beta, but there are several other cytokines which have pro and anti-inflammatory roles, both in psoriasis and problem psoriatic arthritis. They belong to a superfamily. They are in most cases activated through proteases that cleave the propeptides, and this is a most interesting field of research. And these are just some of these cytokines. This is a reminder of interleukin-36. And its activation, the activation of its receptor, the way in which the signaling pathway that eventually activates the expression of genes which lead to a pro-inflammatory response. And we must remember that interleukin-36 acts also on T cells. So T cell, the production of interleukin-17A by T cells is mediated through the binding of interleukin-36 to their receptors, especially in generalized pustular psoriasis. And there's a variant. We might think that this is in the differential diagnosis. That's acute generalized exanthematous pustulosis. This is usually described as a reaction to drugs. It's a variant of a drug reaction. It has more eosinophils. It has more spongiosis, and perhaps a more significant role of natural killer cells than generalized pustular psoriasis. But the mechanisms are very similar. And again, here we see some activation of T cells. This recognition of the role of the interleukin-36 receptor has led to the development of several biological agents, monoclonal antibodies that are started to be studied in terms of their potential therapeutic exploit in generalized pustular psoriasis, in palmoplantar pustulosis, in pyoderma gangrenosum, ulcerative colitis, many diseases in which polymorphonuclears are so important. And there are two of these molecules which are closer to their authorization, or at least in more advanced clinical stage of development. They are spesolimab and imsidolimab. And this is just a reminder of the trials at different phases. And this is on the left, you can see the response of patients following the blockade of the receptor of interleukin-36, and it's the blockade of its binding and activation of the receptor. And you can see the response is very quick. And the proportion of patients who achieve a complete resolution of the disease gets close to 100% after just 4 weeks. You can see that this is a very quick effect we are seeing here. So these drugs are being developed not just for the induction of the clearance, but also for the maintenance and prevention of relapse. So there are two main drugs. Spesolimab is a bit more advanced in that respect. And it is important to remember that this regulation of interleukin-36 has also been recognized in psoriatic arthritis. So there are differences between in the synovium between psoriatic arthritis and rheumatoid arthritis. You can see here that the ratio between interleukin-36 alpha and its antagonist is very high in psoriatic arthritis, and it's approximately the same in rheumatoid arthritis. We know that the synovial fibroblasts derived from psoriatic arthritis synovium are more responsive to the stimulation by interleukin-36 as compared to rheumatoid arthritis fibroblasts. And we know also that at least in psoriatic arthritis, but not in rheumatoid arthritis, higher expression of synovial interleukin-36 predicts inadequate response to DMARDs, to disease-modifying anti-rheumatic agents. And these are just some final words to remember that currently the treatment of psoriasis is based on the blockade of this interleukin-23, interleukin-17 pathway, that blocking the distal cytokines might lead to a more rapid effect, and also to perhaps more effect in terms of axial psoriatic arthritis. We will be discussing that in a moment. But that blocking the regulatory cytokine, interleukin-23 is the main regulatory cytokine, might induce a persistent response and with a highly convenient frequency of administration. It's also important to remember that depending on the drug that we are using, the safety profile is different. So if we are blocking tumor necrosis factor alpha, which is so important as an anti-tumoral and antiviral agent, we might run into some problems in terms of hepatitis B, in terms of the worsening of heart failure, and also worsening or appearance of demyelinating diseases. And the most important consideration is the risk of, let's say, lysis of granulomas and the activation of latent infections by intracellular pathogens. This applies, of course, to tuberculosis, but also to coccidioidomycosis, to leishmaniasis, even Chagas disease. So this is something that we must take into account when we start treatment with an anti-TNF alpha agent, which in many cases, at least in Europe, is I wouldn't say compulsory, but almost, because of the convenience in terms of efficiency of the biosimilars. On the other hand, if we block the peripheral, the effector cytokine, that's interleukin-17A, and also F, this can be blocked by some drugs which are under development, for instance, bimekizumab. We are blocking the response against candida, especially in terms of mucosal candidiasis. We are also blocking somehow the defense against dermatophytes, and some extracellular infections such as Staph aureus. So it might be in terms of preventing this occurrence in some patients to use a blocker of the radiocytokine, because there are many redundant pathways that might provide the effector distal cytokine that is required in case of these infections. And finally, we know that in the intestinal epithelium, the integrity of the intestinal epithelium depends to a large extent on interleukin-17, which is released and produced independently of interleukin-23. So this production of interleukin-17 is not blocked by interleukin-23 inhibition, and this might apply to, for instance, inflammatory bowel disease. But when we are blocking both interleukin-23 dependent as interleukin-17 in production independent of interleukin-23, we might run into problems as regards the activation or the triggering of inflammatory bowel disease that we all know that is more prevalent per se in patients with psoriasis, psoriatic arthritis, and especially in patients with ankylosing spondylitis and other spondyloarthropathies. So this is the advantage from a safety perspective of interleukin-23 blockade, even though I would say that we all know all biologicals have a highly reassuring safety profile. And just finally, I would like to remind you that the same applies in psoriatic arthritis. There are very different phenotypes. Most of the clinical trials in psoriatic arthritis are centered on patients with peripheral polyarticular disease, which is a minority of patients. And we must remember that both interleukin-17A and tumor necrosis factor are very important in terms of driving the activation of osteoblasts, which are so characteristic of the osteoproliferation, so characteristic of psoriatic arthritis. And in that respect, interleukin-22 is very important. And on the other hand, tumor necrosis factor is together with interleukin-17 is a driver of the activation of osteoclasts that lead to bone resorption. And in this role, the cytokines interleukin-1, tumor necrosis factor, and interleukin-6 are important, but we must remember that their role is not so important in psoriatic arthritis and in ankylosing spondylitis as it can be in rheumatoid arthritis. So there are some differences in the mechanisms of inflammation and the mechanism of activation of osteoblasts and osteoclasts, and consequently in the relative prevalence or presence of bone formation versus bone erosion in these different diseases. And finally, I would say the take-home message is that we have been reviewing this paradigm of imbalance and activation of the innate and adaptive immune response, that interleukin-17 is the main effector cytokine, mostly regulated by interleukin-23 and acting in synergy with the tumor necrosis factor. But the keratinocyte-derived cytokines have a feed-forward and self-amplifying loop, which is highly important. And in that respect, the blockade of interleukin-36 is highly promising in terms of especially controlling these rare variants of pustular psoriasis and also in other diseases. And these cytokine networks, including interleukin-17, interleukin-22, tumor necrosis factor alpha, and very likely interleukin-36 are active in psoriatic arthritis and spondyloarthritis, where the response and the trigger is mechanical stress, and that differences in cell populations and in cytokine regulation may account for differential therapeutic responses at odds with those in psoriasis. So perhaps a blockade of IL-23 might be more effective in axial disease if we use it early, whereas when the disease is more advanced, or when there's a prominent endothelial involvement or the prevalent activation of interleukin-17, we might need some other drugs such as TNF, tumor necrosis factor antagonists, or interleukin-17 inhibitors. And that's all of my presentation. There are some questions for you, and also I'm more than happy to answer your questions. Thank you. Let's see, there's some question in the comments. Could messenger RNA-mediated treatments have a place in the treatment of psoriasis in the coming years? Really, I doubt that there's such a need, especially when we are able to provide almost 70% complete clearance in the long term in our patients. So I really don't expect that in the case of psoriasis. It might be different in some other diseases, in fibrotic diseases and the like, but I don't think that this would be the case in psoriasis. Thank you to all the participants in the webcast. My goal was to not just to present data, but also to elicit some, let's say, questioning or some thoughts, because the important the questions to be making questions might be more important than than answering them, because perhaps making the right question will provide the basis for developing new studies, new strategies for pathogenetic research. Thank you. A special salutation to Dr. Gallardo, who is over there. Also Maria del Carmen Fuertes, David Harut Yunyan, Mustafa Anil Yilmaz, Habel Sayed, also a big hug to them. Dina Senun. And please don't hesitate to send me or to addressing me any question, any request for references, whatever. Thank you very much. And we've just renewed Messi for a couple of years more.
Would you like to expand on anything while we're waiting for questions?
I didn't want to discuss to a large extent some of the other interleukin-1 cytokines, but I really do expect that new drugs will be available to block these cytokines. And I have some expectations also regarding the interleukin-10 family of cytokines in terms of psoriasis and proliferative and disease characterized by epithelial proliferation. But all in all, we are very happy as compared to our gastroenterology or rheumatology colleagues in that we have very excellent drugs available, which so that personalized medicine would be required in just perhaps 10% of our patients. And that's a big advantage. We cannot compare ourselves with situation in oncology. The recognition of different phenotypes and the different drivers of the different endotypes in each phase of the disease, which also make change over the course of disease, is also important. So one of the main issues we can have when treating a patient for psoriasis, for instance, with an anti-TNF-alpha agent or an IL-17 is what happens, or what should we think when psoriatic arthritis develops? Are we not blocking the driver, the mediators enough? Has there been a change in endotype? Is that paradoxical psoriatic arthritis, whatever that is? And in paradoxical, learning more about paradoxical psoriasis, for instance, we can learn more about the ways in which to treat these different endotypes. For instance, unstable psoriasis or generalized pustular psoriasis. We must remember that some of the manifestations of paradoxical psoriasis are strongly pustular.
Absolutely. Now, at this point, we haven't received other questions, and I can only assume that the complexity and the depth of this talk has satisfied our watchers. We've actually had a lot of positive feedback, very engaged audience, but they don't have a lot of questions today. So I would like to take a moment and thank you very much for joining us today. Thank you for the time you took to put this presentation together, for speaking to our members and our audience. And we would like to also thank our audience out there. Thank you for joining us today. Thank you for sharing your thoughts, your question, and your feedback. Now, the EADV is proud to offer numerous opportunities to stay on top of the state of the art in all things dermatology and venereology related. After more than a year And this is exciting. After more than a year of tough pandemic restrictions, we are proud to again offer face-to-face courses. Until the end of the year, we will be exploring the topics tropical and travel dermatology, dermatopathology, mycology, and surgery on cadavers. Also, the EADV will have the first ever courses for nurses in dermatology practice. Apply now, and you may find yourself in Lisbon, Barcelona, Malaga, Copenhagen, or Verona studying among other up-and-coming doctors and specialists. The first applications close on July 1st, so make sure you visit www.eadv.org/education before the deadline. Seats for specialists are limited and on a first-come, first-served basis. COVID safety measures will be in place. On the 7th of July, join us for our next webcast, Botulinum Toxin Off-Label Use in Dermatology. And at any time, you can check out the Dermatology Podcast, EADV's official podcast, available on all major podcast platforms, including Apple and Spotify. Don't forget to follow or subscribe. Thank you again for joining us. Thank you to Professor Puig, and see you next time. Have a pleasant day.